So I'm Sarah Danson. I work in Sheffield. I see some familiar faces out there. This is my third time up on the stage. This is one of the most tense talks that I give because you can just ask me anything, whereas usually I know kind of what's coming from the audience. Plus, I have the timer on the front here who will hold up it if I'm overrunning. So, of course, we can't cover everything, but I'm just going to give you an overview. So I last did this 2 years ago. There have been quite a few changes happening since then. So we've always sold ourselves in the UK as being a place where we can really, really run clinical trials. We've had the National Cancer Research Institute, the NCRI, where we get the ideas. We've got patients involved at that stage as well. We design the trials. We've got a portfolio of trials. We make sure we're asking the right questions. And then we deliver the trials through the NIHR, that's the National Institute for Health and Social Care Research. And the way that we've done this is that we've had strong links between the NCRI and the NIHR. So the top box is all the clinical studies groups that we had from the point of view of specialities. So skin cancer is very much in there. The NCRI is here as well with its groups too. And then we've had national leaders, so 6 national speciality leads who have been based in the NIHR. So I've been one of those. I've been doing the early phase research side of that. But everything's changing. So out of the blue, we suddenly found out that the NCRI was winding down after 22 remarkable years. I would dispute winding down. It was literally the announcement came out and then it was finished the next day. And I think it's fair to say that we were stunned by this because we felt so many good things had come out of it, including, of course, the NCRI skin group, which many of us have been members of and which had produced a lot of the trials that I'm going to touch on now. The good thing from a skin cancer point of view is that it was immediately picked up by the oncology community. So Brent O'Carrigan, who I believe came and spoke to you, did a workshop last night, was the deputy chair of the NCRI skin group. And he set up the UK Skin Cancer Clinical Trials Group with its 3 subgroups, one looking at early stage melanoma, the second at more advanced melanoma, and the third non-melanoma skin cancers, which again are very important. And we're just getting going with this, really. We're going to have monthly meetings to discuss activity and also to bring clinical study proposals through as well. Of course, we also have the brilliant Melanoma Focus, which again was already doing a lot of work, which has meant that we haven't kind of dropped down to back to where we'd begun by any stretch of the imagination. So you know, as we'll keep mentioning, this is a real plus that we have this. When I came 2 years ago, these were the questions that I thought still needed to be answered by research for melanoma. So I'm giving drugs to everybody, but who should I be giving them to so that they respond? You know, do I need to be looking for something in the tumour like PD-L1? Do I need to be thinking about what's happening in the gut microbiome? What trials can we have for patients with brain metastases? What do we do beyond a BRAF mutation? Because you know that's just one way that the tumour can evolve. And when should we give these drugs? How often should we give these drugs? Are there better drugs, which I'm sure there are, and that are coming through as well? And which drugs should we combine together? So I haven't solved all of those things in the last 2 years, but we are continuing to work to do so. So these are the melanoma focus trial finders. We used to have NCRI portfolio maps, which were sometimes up to date, sometimes not. These are a real resource. So thank you, Nikita, for all the work that you do in keeping these up to date. So this is from earlier this week. And 19 trials were on the melanoma focus trial finder in 45 locations. You may have your own thoughts about that. You know, that if you are living away from one of these dots, you are disadvantaged in terms of being able to get a trial because it is harder to travel for a trial. Anyway, If we look at what stages of melanoma these trials cover, as you'd expect, the vast majority are in more advanced disease, the stage 3 and 4 disease. If we look at who's bringing these trials to the table, 1 from dermatology, 2 from plastic surgery, 3 sample collections, 1 database study, and 12 drug trials. So I'm going to go through those. So Mole Gazer is the dermatology study. So dermatologists spend a lot of time using their dermatoscope looking at moles, but are they looking for the same things, the A, B, C, D, E that you've just seen on the video? Could artificial intelligence be doing that as effectively as a dermatologist? I think we're still going to need dermatologists, but are there certain lesions that we could be using an algorithm and artificial intelligence to look into? From a plastic surgery point of view, the first study is Melanoma 2. So we've always, as many of you will know, when you've had your primary melanoma taken off, you then have a much wider excision done, a 2 centimetre excision. But that's a lot of skin, 2 centimetre on each side. So could we do it with narrower margins? So Melanoma 2 is looking at 1 centimetre margins. And then MARM, I do like that acronym, is microwave ablation of cutaneous metastases. So it's not going to deal with anything that's inside, but it's about doing microwave therapy to try and shrink down any metastases that are in the skin. In terms of samples, 2 years ago, I talked about the MITRE study, which is this huge collection where we're collecting stool samples from patients on immunotherapy, and that's running around the UK. And hopefully we'll start seeing the data coming through with that. We're also collecting lots of clinical information about if patients are on antibiotics, if they're on statins, PPIs, and so on, that could change the way that the microbiome works. The MIST sample collection is taking the skin specimens and also blood from patients with melanoma. And then the Liverpool Ocular Oncology Biobank, I won't be taking any questions on, as we've got Dr. Sacco from Liverpool over there in the audience. I believe you heard a lot about my melanoma last night, so this is the database study. This is just going to be such a rich source of information for us. Anyone can sign up to this and put their information in. And then drugs. I must admit, this is the bit that, this is my area of expertise. These are the drug studies. So I've tried to, you will have the slides, I've tried to sort them out. So the first 3 are for patients who've had surgery or are about to have surgery. Then we've got the first line studies, and then we've got the studies for patients that have already had some first line treatment. I know you won't all be interested, but lots of you will be really interested in the molecules that we're targeting with these drugs. So KeyVibe is an immunotherapy study. TIGIT is part of the immunotherapy pathway. Then we've got the cancer vaccines, and I'm going to talk more about those because this is something I'm really, really interested in. Next, we've got a BRAF/MEK study, Premium, which is trying to shrink down disease before we do the surgery. And then we go on to the SCOPE study, which is another cancer vaccine, SCIB1. Then 2 immunotherapy duration or intensity studies, Dante and Refine. Then we've got R3767, which is another immunotherapy, so targeting LAG3 this time. And then we've got tebentafusp. So again, Joe will be well placed to answer any questions about that, but I talked about that 2 years ago in detail. So that's taking blood samples, looking for evidence of the disease coming back again, and giving patients treatment earlier rather than later. And then we go on to our second line things, and these are all immunotherapy type things. So tumor infiltrating lymphocytes, cytokines, taking the tumour sample and looking at what abnormal cells are in the tumour, and oncolytic viruses, which I've always found a very rational way of doing things, is that you put a virus into a cancer cell and the cancer cell explodes when the virus divides. So to summarise that, it's mainly immunotherapy still. We've only got 1 BRAF/MEK trial that's going on there. As I've said, 2 of them are post-operative, 1 is before and then after surgery, and 9 are for advanced disease. So I'm going to talk a bit more about Refine and one of the cancer vaccine trials. So Refine is, these slides came from Sophie Merrick, who's the clinical fellow for the Refine study. Lots of us think that we're probably giving too much immunotherapy. We know that we often have to stop immunotherapy, and yet people's tumours continue to respond. So it'd be really nice if we could definitively show that we can give less immunotherapy to people and still have a good effect. You then have fewer visits to the hospital, fewer blood tests, hopefully fewer side effects, and of course the NHS, which is creaking at the seams, would benefit from it as well. It is always difficult to talk about reducing the amount of treatment that you have. We have to think about quality, quantity, but we are taking away kind of the life ring. It can feel like we're putting people on the edge of the precipice, looking down without anything to hold on to. So we do have to do this for the right reason. So this is the REFINE trial, and the blue lines are treatments. So the blue lines at the top are the standard treatments, the way that we give it now. So these are how often we give the immunotherapies. And the line at the bottom is what we'd like to be doing, so halving the amount of times that we give the immunotherapies. So this can be for either nivolumab, which would go from 4 weekly to 8 weekly, or pembrolizumab, which would go from 6 weekly to 12 weekly. This is happening in melanoma, but we're also doing it in other tumours as well, such as lung cancer and kidney cancer as well. And then coming on to cancer vaccines. So my conflict of interest here is that I'm the co-clinical lead nationally for the cancer vaccine programme. We did incredibly, as you'll know, in COVID research during the pandemic. These big studies, the recovery trial, that's thousands and thousands of patients that went into, they're UK studies. We all did research into COVID and cancer as well, from the coronavirus project, which was a database project again, to looking at how patients who were having cancer surgery did in COVID surge, and to even, I did one looking at the mental health burden for staff working in the NHS. So we can do this type of research. So when I talk about a cancer vaccine, it's not quite the same as a COVID vaccine. So if it was, it would just be about preventing the development of cancer. But a cancer vaccine can actually also be a vaccine that treats an existing cancer. So what we do is we give the cancer vaccine, not usually into the thorax, which is the chest, which is how it looks there, intravenously or subcutaneously. That cancer vaccine will have abnormal cells in it, activate the immune system, and the immune system will then learn to attack those types of abnormal cells. And there's two ways that we can find those abnormal cells. One is to look at a tumour type and say, these are the types of abnormalities that we see in this tumour type, and then develop a vaccine that will hopefully suit most people. So actually off the shelf, just take it off the shelf in Boots and give it to the patient. Not quite that easy. Or, even cleverer, we take the patient's tumour and make an individualised vaccine. So we make the right vaccine for that tumour. I have put a case study in here. So some of you may be X or Twitter active, like I am, and Richard Scolyer is very active on Twitter. He is an Australian pathologist, a melanoma pathologist. He's the co-medical director of the Melanoma Institute in Australia. And he works closely with Georgina Long, who's done so many of our melanoma trials. She's amazing to listen to if you ever get the chance to do so. As you can see, he's a young man, and whilst on holiday with his family in June 2023 in Poland, he had a seizure. This turned out to be a glioblastoma, helpfully circled by the man himself, so that we can all see where the abnormality is on his brain scan. And he proceeded to have some standard immunotherapy that we give for melanoma, then followed by surgery. So Georgina was out there trying to work out what to do for her colleague, what was the best thing that she felt she could give him. And patients with brain cancer don't usually have many treatment options at all. He has been receiving a personalised cancer vaccine for his tumour. As I say, he continues to post. He smiles in every post. He's on the left. He's having his cancer vaccine. In the middle, he's having his scans. Patients with glioblastoma typically only live a few months. It's an absolutely horrible disease. He's now 9 months out, and this is his latest scan. The hole is where the surgery happened, but you can see there's no evidence of any recurrence of the tumour there. So this is the type of thing, the potential, hopefully, that cancer vaccines have. BioNTech and Moderna were the ones that gave us the COVID vaccines during the pandemic, and they have both signed up to huge initiatives in the UK. So BioNTech wants to give cancer vaccines to people. They also want to be ready for if we have another pandemic for infectious diseases. So they want to have the capability to just start giving 10,000 infectious disease vaccines from a UK manufacturing facility. Moderna has signed up to a 10-year deal with the government where they will bring the majority of their clinical trials, infectious diseases and cancer vaccines to the UK. This is one of the first studies that's come through. So there's a lot of name in that title, a lot of letters and numbers, but Keynote 942 is what most of us tend to call it. This was a smaller trial in patients who had had their surgery for melanoma. So stage 3 or 4 surgery, and were disease-free at study entry. They were randomized to either pembrolizumab as an adjuvant treatment or to pembrolizumab with the cancer vaccine. The cancer vaccine is an individualized one, so the best of the best, as it were, from that point of view. And what we've been looking at is what happens to recurrence in those patients. So the first take-home messages are that there is a significant reduction if you add in that cancer vaccine, a 44% reduction in the risk of recurrence or death at 2 years of follow-up. This has obviously excited a lot of people. And the good thing, because we often give more and create more problems, is that that is well tolerated. We aren't putting more patients into hospital with those side effects. So it's being accelerated as often major breakthroughs are. The great thing from our point of view is that there is a phase 3 study going now, so we need to confirm that this first result is real. And this is enrolling in the UK. So Heather Shaw is the UK chief investigator for that. She's based in London, but there are various other sites around the UK as well. We want to put people into these studies, and we want to get the next lot of studies to come as well. So I think that's really exciting stuff. So to come back to my unanswered questions, still all there, hopefully moving in the right direction. We'd add in vaccines to the better drugs and techniques as well. I think, in the question and answers, it would be great if you could tell us what you actually want us to be looking at, what we're missing, because that is the portfolio. So where are the gaps? I know you've got talks this afternoon about late effects. That's certainly something that we need to be thinking about. So it's easy for us to do the prescriptions, but what are the side effects that come after that? What's happened to you 20 years after you've had immunotherapy? Is it worth it in the long term? So to summarise, hopefully I'm on time. There is melanoma research ongoing in the UK, and despite our setback with the NCRI side of things, and the NIHR as well is going through a reconfiguration, we're still moving forward, and it's because we've got these great groups in place. We're still doing a lot of immunotherapy trials, and I don't think immunotherapy is going to go anywhere. It's changed everything, and hopefully we just work out how to give it better and what to combine it with. We do need the next lot of research ideas, so always happy to hear thoughts. And as I alluded to from those maps, I'm very concerned that there are areas of the UK where people are not getting these trials unless they're prepared to really travel. And so the better that we can get at placing studies, and the more that we can support people to get to the trials if they want to be on them, and the quicker that we can get them into standard of care so they're in more hospitals, the better. So that's my email and X number if anybody wants it. But thank you very much for listening.